almost every agent we use or classes of agents, I mean, can cause this. So I can go through a whole list for you, but I'll summarize. Agents like bleomycin we know can cause that. We rarely use bleomycin. Primarily, it's used in the GU world. Gemcitabine is a biggie, and we use it quite a bit in pancreas and biliary, and of course in lung cancer. But in my world, primarily in pancreas and biliary. And gemcitabine has a rate of about 2%, say. TKIs, we don't use as much a lot in it, but that certainly can do that. We use quite a bit of EGFR inhibitors such as panitumumab and cetuximab, and those can cause these type of interstitial lung disease at a rate of 1%. So for our EGFR inhibitors, monoclonal antibodies, we can see that. These tend not to be too severe, but when you see them, again, you have to stop the drug. So panitumumab, cetuximab, are examples. Irinotecan, as I said, you can see it in less than 1% of the patients. It has been reported. I frankly have seen, I think maybe one or two patients in my last 20 years with irinotecan. Incredibly rare. And I think the quality of reporting for this is low. So I'm not sure that one can say this is a risk factor, but it's something that to keep in mind, at least in my world. Then we have nivolumab, pembrolizumab. The problem with those again is that is it really interstitial lung disease versus initially just an immune-related event that is reversible, where you can reuse the drug if it's mild, versus true interstitial lung disease. And we see quite significant risk of ILD, at least more significant than in the Western population with these agents in Asian populations versus Western populations. One can go through a whole list of agents that certainly can cause these. I mean, there are some non-chemotherapy agents, not to belabor over it, because we see some of these patients, such as patients on amiodarone, if they have history of atrial fibrillation, that can have an increased risk of interstitial lung disease. So if you have your patient, let's say, with colon cancer, who has history of AFib, uncontrolled, and has been placed on amiodarone, it's unknown whether, because they have the amiodarone and you give them an agent that has also a risk of ILD, whether you increase the risk. That has not really been studied. But then it gets confusing, which is driving which. Is it the amiodarone or the agent itself? But that's something to certainly think about. Nab-paclitaxel and the taxanes also, unusually can cause these types of reactions. So any agent, any cytotoxic agent, and a number of these TKIs, PD-1, PD-L1 inhibitors, and of course now these antibody drug conjugates can cause interstitial lung disease at various rates. In the world of oncology, we work with a lot of agents that can cause interstitial lung disease at various rates. So as I said, agents like gemcitabine, rarely irinotecan, have been known to be associated with interstitial lung disease at very low rates. And so, the best advice that can be given for those patients with a very low risk is, again, anything that's unusual pulmonary manifestations should lead to at least consideration of oxygen testing as well as chest X-ray. And then perhaps a high resolution CT, which we get anyways from every couple of months on those patients. For those agents, to just leap forward, like these antibody drug conjugates, where the risk is, close to 10%. So that's a high risk. You have to remain very diligent, checking those symptoms, pulmonary symptoms. Take a good listen of the lungs, oxygen saturations. In my clinic, at least, would be checked every time the patient gets seen or gets chemotherapy, and these are important. We are learning more and more about these antibody drug conjugates and their potential toxicities to the lungs. And so, this is an evolving field. What we're seeing, at least with trastuzumab deruxtecan, that you can see in some studies up to 13%, in others less than that. and you can see some death, which I think those deaths could be mitigated with understanding a little bit more, the initial signs and symptoms of interstitial lung disease, and act early by stopping the drug and involving a multidisciplinary team, specifically pulmonologist, in the care of the patient. We will learn more as time goes by, and I think our best bet is for the future is to be able to understand. Obviously, this doesn't happen to every patient, thankfully, otherwise, the drug would not be used. If we can find a way, at least with these antibody drug conjugates, to understand who are those patients who are at highest risk, whether it's clinical characteristics, which as more knowledge comes by from more studies, we may be able to find common characteristics that define who is at risk, but also ultimately, whether it's a pharmacogenomic determinant of of toxicity, so we can spare patients the risk of toxicity, at least most patients who can get that toxicity that's spared. That is something that is being worked on and will be available to us in the hopefully the near future, at least the clinical characteristics, and ultimately perhaps a pharmacogenetic tool that would lead us to select out those patients who are at highest risk.